We're here to talk about factors associated with candidemia in patients receiving micafungin. Invasive candidiasis, although a rare phenomenon, carries a very high mortality risk of 40 to 55% in ICU patients. Therefore, it is critical for clinicians to recognize development of candidiasis and treat it empirically. However, accurately predicting development of candidemia is very difficult. The Candida score is a validated clinical prediction tool that can be used to predict the risk of invasive candidiasis. From various studies done, we know a total score of 3 correlates to an 8.5% chance of invasive candidiasis, and a Candida score of 4 correlates to 16.8 risk, and so on and so forth. Since the start of COVID-19, there has been an increase in the use of micafungin at the Memphis Veterans Affairs Medical Center. As shown in Figure 1, the total micafungin use increased much faster than the true candidemias. Therefore, we aim to identify factors that can help predict candidemia in all patients who are started on micafungin. We retrospectively evaluated all patients at the VA Memphis Medical Center during fiscal years 2020 and 2021. So how is Candida score calculated? There are 4 criteria. Sepsis is worth 2 points, TPN worth 1 point, surgery on admission or surgical complications are worth 1 point, and multifocal Candida colonization is worth 1 point. The sum of all these points represents the total Candida score. We calculated Candida scores for every patient on day of micafungin administration and for the 2 days prior to micafungin administration. We also collected data on the presence of other factors such as diabetes, cancer, central line placement, among others. Let's review the results. First, we're going to take a deeper dive into Figure 2. We're directly comparing the candidemic and the non-candidemic patients. We've mapped out the Candida scores for day -2, -1, and day 0 for both groups. In summary, we can see that the trends of Candida scores for both groups are increasing. There is a greater percentage of 3s and 4s for both groups as we move on from day -2 to day 0. However, for candidemic patients, we can see there is a more robust increase in the percentage of scores of 3 or more compared to the non-candidemic patients. When we calculated the average Candida scores for both groups over the 3 days, we did not find a significant difference, but stratifying the data and closely analyzing the data reveals a clear increasing trend in Candida scores that is more prominent in Candida patients. Next, we'll move on to the other risk factors outside of Candida score that predicted the use of micafungin. We will take a more in-depth look at Table 1 on the next slide. First, we calculated the average age for both groups and found no significant difference. The average BMI was actually higher in the non-candidemic group. Other factors such as pressors at time of micafungin administration, dialysis, and antibiotics all yielded no significant difference between the 2 groups. The factors that did yield a notable difference were central line placement, cancer patients receiving active chemotherapy, and diabetes. A rudimentary relative risk calculation shows all these factors to have a relative risk of around 2. I'd also like to draw attention to the duration of central line placement to be around 7.5 days in candidemia patients, while it was around 6.6 days in non-candidemia patients. Much to our surprise, steroid usage in ICU as start location of micafungin was not as common among candidemic patients. It was actually higher in non-candidemic patients. We hypothesize that this can be explained, at least partly, by the clinical decision-making in the face of COVID-19. A lot of septic patients during this period had COVID sepsis. As a result, all these patients were inevitably treated with steroids. Further, with the unique patient population of the VA, a high proportion of these COVID sepsis patients ended up in the ICU. When clinical decline was imminent, a lot of clinicians seemed to add micafungin as a last resort. As we dive deeper into this data and add the further data points, we expect to possibly note a change in behavior, especially prior to the COVID era. Coming back to the poster now, we also noticed that micafungin use was started in candidemic patients at about 1.5 days after blood cultures were drawn, and a little bit later in non-candidemic patients around 1.9 days. A mortality rate of candidemic patients was 63% compared to the 46% in non-candidemic patients. This indicates that the mortality for candidemic patients were quite high, yet micafungin was started about 1.5 days after blood cultures. All this data points to the lack of a great standardized predictive tool to calculate the need of empiric antifungal treatment. In conclusion, empirical micafungin use in patients was difficult to predict. Candida score, if trended, has some utility in triggering empiric antifungal treatment. However, by itself, Candida scores were not different between candidemia and non-candidemia patients. All these findings suggest the need for a potential modification of Candida score to improve its utility as a predictive tool for empiric antifungal treatment. Our limitations included a small sample size. Therefore, our analysis precluded rigorous biostatistical analysis. Further research is warranted to investigate these factors and propose a modified Candida score for clinical use.